Dear ladies and gentlemen, welcome to another webinar brought to you by the Malaysian Obstetric Medicine Society. We often talked about a lot of important topics in this webinar, from preeclampsia to proteinuria to diabetes to cancers. But I believe it's time we dedicate one webinar to a very important condition, a silent pandemic that I believe all of us need to be expert in management, perinatal mental health. And ladies and gentlemen, what are the key facts that all obstetricians should know? I've got no conflict of interest in this talk, ladies and gentlemen, but being a maternal medicine specialist, I do see a lot of women who actually suffer in silence. I believe this is also an important arm of obstetrics that needs to be developed. There's a whole load of online group supports, and I believe in perinatal positivity. In fact, this is a group which is easily available online, who dedicate a lot of resources, and they call themselves perinatal positivity, which I believe should be the way forward. So, ladies and gentlemen, in the next 30 minutes, I'm going to talk about three things: the significance of mental health, how to screen, what are the red flags that all obstetricians should know, and some principles of care. Ladies and gentlemen, we know that the incidence of preeclampsia can be about 15 to 20%. The incidence of GDM in Malaysia is also 15 to 20%. The incidence of preterm deliveries is also about 20%. The incidence of Down syndrome depends on the mother's age, and those are all well-known facts. But what are the numbers of mothers who experience mental health symptoms during pregnancy, ladies and gentlemen? Is it higher? Is it similar? Or is it lower? The answer is 1 in 5 women with a similar incidence of preeclampsia, preterm delivery, and GDM also suffer from a mental health illness. It is often unseen, it is often undiagnosed, and that remains a major challenge in modern obstetrics. It may not be as high as anemia, but it remains a significant medical condition that most maternal medicine experts like me see in my own clinic. Apart from mental health, based on the last triennium confidential inquiry report, 62 women died sadly from suicide, and 58 actually also take substance misuse, which is also incorporated into the big umbrella of mental health. So, ladies and gentlemen, it remains significant. It is common. It is often undiagnosed. It is we who should look for the small cues, pick up, to treat, to support, and to diagnose. I'm going to talk about certain definitions. Now, what is the definition of perinatal mental health? It is a mental health illness that happens during pregnancy and up to 12 months following childbirth. It is not the traditional definition of 6 weeks or 42 days, but it is 12 months, and it is that common and is slightly different than most other puerperal definitions. Another commonly used term is IAPT, which is improving access to psychological therapies, a condition which is commonly used in the community by psychiatrists and counselors. And this includes talking therapies, psychological therapies, monitoring, and focused supervision. And this is actually one of the first lines of management commonly used for mild diseases in those who are in the community. The second term that I believe all obstetricians should know, apart from IAPT, is CBT. And CBT actually means cognitive behavioral therapies, which involves a change in thinking patterns, which involves coping strategies and problem-solving strategies. So, ladies and gentlemen, IAPT and CBT are some terms that all obstetricians should familiarize, apart from the safety of medications during pregnancy, which I will surely highlight in this talk. Let's take a look at the significance. Now, this is the confidential embrace inquiry reports from UK for the period of 2017 and 2019. The leading cause of maternal death is, of course, cardiac diseases, followed by neurological diseases. Sepsis is number 3. VTE has number 4. But mental health illness, ladies and gentlemen, is the 5th leading cause of maternal death, even more than hemorrhage, more from other indirect causes, more from preeclampsia, more from malignancies, and more from early pregnancy deaths, and that is the UK data. The UK Embrace data also has got a wonderful report of following up these patients up to a year. And based on the same triennium, the incidence of suicide up to a year following childbirth is as high as 18%. The incidence of drug and alcohol abuse is as high as 16%, only to be beaten by coincidental malignancies, which are 19%. So, ladies and gentlemen, it remains significant. Even in Malaysia, I believe even in most developed countries, in the UK, in the US, mental health is extremely significant. I believe, hence, we as obstetricians must rise to the occasion, must educate ourselves, must be comfortable in managing mental health issues among pregnant mothers. Let's talk about suicide, ladies and gentlemen. We do know, based on the confidential inquiry reports and the Embrace reports, that if a lady suicides, it often is more traumatic. The most common cause of suicide is hanging, almost 62%. It is followed by overdose, traffic or train accidents, fall from height, where we still hear news in the headlines in Malaysia at least once or twice a year, followed by carbon monoxide poisoning, drowning, and suffocation. But if it's a woman, if she's pregnant, she was to be suicide, it's likely to be more traumatic as compared to men. That is what the study says. But these are often not actually events that happen before pregnancy, but some may also be related to adverse pregnancy outcomes. 5% of them who actually had suicide had a pregnancy loss. 2% had neonatal loss. 15% following a termination of pregnancy. 16% following an infant removal from the care of relatives or social services. 63% had no known loss events. So, ladies and gentlemen, as obstetricians, if you already had a disease or if there was adverse pregnancy outcomes, it could be a hysterectomy, it could be a pregnancy loss, it could be a preeclampsia, it could be a preterm delivery. I think it is important to screen, treat, and follow up, because this patient now becomes high risk. Now, why is it still a taboo among obstetricians? And I think this beautiful paper by the TOG wonderfully summarizes why is it taboo. Because I think it's still a stigma of patients and obstetricians and midwives to talk about mental health. I think it's time we break the taboo. We are still very apprehensive to ask the directed questions. Are you depressed? Are you anxious? Have you been happy? Are you your normal self? I think it's time we ask. But often we don't know what to ask. We just remain silent and look for cues. It is okay to ask a directed question. Sometimes we fear of patients to disclose. I believe that should not be a cue. But ladies and gentlemen, I think the problem lies in how well are we all trained in perinatal mental health. I believe training in medical school in the obstetric curriculum is extremely important. Every single personal healthcare professional caring for pregnant mothers, be it doctors, be it midwives, should be comfortable and should know how to screen for perinatal mental health. Finally, we also need to know, apart from what to ask, apart from when to ask, what to do when a woman disclosed. And I believe these are certain common things that I think we should be comfortable in. Now, who are the patients who are at risk of mental health? We can divide them into two cohorts. The first cohort is a patient with existing major psychiatric illness, a patient who's got a known to have bipolar, a patient who's schizophrenic, a patient who's known to have mild to moderate depression or anxiety, a patient with mental health conditions but may have some high-risk pregnancies, a patient with family history of psychiatric illness, unplanned pregnancy, where almost 1 in 2 pregnancies in these parts of the world remain unplanned, But more importantly, a patient with an adverse pregnancy outcome, a stillbirth, a fetal loss, a miscarriage, a termination are some of the risk factors. It's also more common among immigrants, among patients who don't speak the language, patients who misuse substance, and some patients with complex psychological needs. And these are generally the cohort who are at a higher risk. Now, how should we approach? First step, establish a rapport. It is important to be comfortable to be speaking to patient, not just about a physical health, not just about a fetal assessment, but also about her mental health. Now, the doctor-patient relationship should be a therapeutic relationship. Although the patient often sees you for a pregnancy which may still appear normal, the patient should have the trust to reveal herself, to break her silence, to understand that it will not be disclosed, but to remain professional, maintaining her privacy, but comfortable enough for her to. As obstetricians, it's important to look for cues and probe history. Mental health, a woman will not often always come forward and say, I am depressed. Look at cues. Does she have anxiety? Is she having problems sleeping? Do not say it is normal in pregnancy. Is her pregnancy high risk? Is she having any panic attacks? Look for cues. Who follows her to the clinic? Does she tell you about what is happening at home and work? These are important cues. If she does not tell you, it is okay to ask specific, directed questions to establish risk. Apart from medical history, apart from obstetric history, it's also important to take a psychiatric history and examination, and this should be part of routine antenatal and postnatal care. It's important to communicate with midwives and psychiatrists, but I believe obstetrician should be the lead, should be the person owning this patient, but it's important to network with counselors, with community midwives and psychiatrists to provide holistic care. Now, what are the important principles of mental state examination? Take a look at how the patient appears. Take a look at a speech. She may be apprehensive if it's the first visit, so take a look at her mood. Take a good history, speak to her, appreciate her thoughts. You might actually do an informal mental state examination. Understand her perception, which I believe every single senior obstetrician should know. Assess the cognition, know insights, and these important 7 facts are important as part of a mental state examination. You don't actually have to formally assess her, but this can be 7 important points to assess the mental state. Next, universally screen every pregnant mother for 2 conditions, depression and anxiety. So what are the questions that you ask to screen? So every mother in the first antenatal and the first postnatal contact, ask everyone the woolly questions. Ask them 2 questions. Have you been bothered by feeling down, depressed, or hopeless? If she says no, ask a second question. Have you been bothered by having little interest or pleasure in doing things? If she says no, that is fine. But if she answers yes for either of these 2 questions, you need to move on to the next step. The next step is to use a questionnaire, and you can have 2 options, either the Edinburgh Postnatal Depression Scale or the Patient Health Questionnaire. You can use one of these 2. The Edinburgh Postnatal Depression Scale is currently available in the Malaysian antenatal book. It's also been translated in the local language. You can use either one of that. If she screens positive, where she gets a score of 10, it's important to refer to a mental health professional. It can be a midwife, it can be a maternal medicine specialist, it can be a psychiatrist, it can be someone or anyone who's trained, but do not remain silent, do not take it lightly. Now, what is the Edinburgh Postnatal Depression Scale? There are 10 questions, and all you need to do is to ask these questions, assessing her symptoms in the last 7 days. There are few asterisks in these 10 questions. Some have an ascending or order of score from 0, 1 to 3. Some have a descending score, but it's important to counter check to make sure you score correctly. But always look at the most important question, item number 10. You don't really have to score 10 if your item number 10 is significant. Anyone who scores greater than 10, think of depression is at risk. The maximum score is 30 for the 10 questions. Alternatively, you may use the patient health questionnaire. In the last 2 weeks, have you been bothered by any of the following? You can have this questionnaire. There are 9 thoughts. But if the Edinburgh postnatal question asks about question number 10, the patient health questionnaire, take a look at question number 9. And the score is the same. If it's 1 to 4, it's minimal. 5 to 9 is mild. Anyone who scores above 10, think of referral. The patient may have moderate depression. And anyone who scores above 20 has got a severe depression. Now, which is better? I think the Edinburgh postnatal score detects 2 things: depression and anxiety, although it was traditionally made for depression. The patient health questionnaire number 9, on the other hand, also can detect somatic symptoms. So both are good, both are validated. You may choose to use one, but both are equally sensitive to diagnose depression. Having been screening for depression, where every pregnant mother in the first antenatal and the first postnatal contact, the second question that you should ask all pregnant mothers is to screen for anxiety. So for anxiety, you can use the general anxiety disorder questionnaire number 2. For all pregnant mothers, ask them 2 questions. Question number 1, how often have you been bothered by feeling nervous, anxious, or on the edge? If she says no, ask her question number 2, how often have you been bothered by not being able to stop or control worry? If either one of these 2 questions she says yes, move on to the second part of the questionnaire. For Edinburgh postnatal questionnaire or the patient health questionnaire, there are 2 types. The anxiety, there's only one, is the GAD-7. And we screen high risk or we screen positive. The patient needs to be assessed and referred to a mental health professional. The take-home message from this slide, ladies and gentlemen, for all patients, universally ask 2 questions. 2 questions for depression, 2 questions for anxiety. If they screen positive, go on to the questionnaire. If they screen positive, refer. Now, what is the difference between GAD-2 and GAD-7? Now, GAD-2, it's simple. It only has got 2 questions that I believe every healthcare professional taking care of pregnant mothers should be familiar with. GAD-7, on other instance, has got 7 questions, an additional 5 from the 2 questions from the GAD-2. The patient scores high risk. The patient has got anxiety. Do not say it is normal. The patient needs to be referred to be seen by an expert. So having screened, having appreciated the significance of mental health disorders, let's talk about some principles of management, which I hope everyone after listening to this talk will be able to comfortably manage, or at least to appreciate the importance about diagnosing, screening, and managing patients with mental health illnesses in pregnancy. So every obstetric unit, ladies and gentlemen, apart from having a high-risk pregnancy unit, apart from having a gynecological unit, an obstetric unit, or an early pregnancy unit, I think it is important to have a coordinated care who's an expert or who's a specialist in perinatal mental health. And in my unit, I am the named obstetrician for any woman who's got a mental health disorder. Important to have a named lead consultant. It's important to assess all women who are at risk, either women who have had a past mental illness, family history of mental illness, or an adverse pregnancy outcome. This group should be able to advise, manage, monitor, and yet again look for red flags. I think there should be considerations for mothers with adverse pregnancy outcomes because they may present for the very first time during pregnancy. It's important to break barriers. Mothers should be able to self-refer. Doctors should not gatekeep. Anyone, including a midwife or a junior staff, should be able to refer to these clinics, and patients should have easy access, 24-hour access to these units if they have got any identifiable risk factors or red flags. How about pre-pregnancy care, ladies and gentlemen? I think it's a balance, the risk of untreated mental health illness as compared to the risk of medications. But the principle is there's no single most important medication that is absolutely contraindicated. I think it's important to see them in the pregnancy, talk to them about the benefit and risk, talk to them about how you can reduce or modify. But the aim is not to completely stop the medications. The general time frame from an acute event to conception, it is 2 years. Although it is just a general guide, it is not an absolute guide. Provided the patient has been well, the patient has been stable on a stable medications, I think pregnancy is not contraindicated. Just like any other medical disorder in pregnancy, for example, epilepsy, the aim is to use a single medication at a higher dose as compared to the use of multiple medications. And that seems to be the aim. You should not ideally be on sodium valproate, which is actually contraindicated among women in the reproductive age group, especially doses beyond 800 milligrams. The patient is on sodium valproate. The patient needs to be on contraception. It's important to see an expert to try to modify medications. Although lithium is usually not preferred, it is not an absolute contraindication. You may check lithium levels in pregnancy. Patients who are taking lithium has got a small increased risk of congenital cardiac malformations. It is important to check levels if you are unable to modify the medications. And the third medication after sodium valproate and lithium is paroxetine. Is usually not preferred among pregnant mothers because of the risk of persistent pulmonary hypertension in these patients. But various other SSRIs like fluoxetine are actually quite safe in pregnancy. And these are the principles: screen, modify, minimize, single agent, talk about benefit and risk are the principles of pre-pregnancy care. How about who needs a specialist perinatal care review? I think any patient who has got a past or present severe mental illness, any patient with moderate or severe depression, any patient with a new onset of psychosis, any patient with the question number 10 or question number 9 becomes positive with suicidal thoughts, any patients with red flags that I'll discuss after this, any patient with a past or a present treatment for severe illness, or any patient with a first degree family relative with a severe mental illness, these are the 7 cohort of patients who actually need specialist perinatal health review, should ideally be reviewed in a dedicated perinatal mental health clinic. What are the red flags, ladies and gentlemen? I hope that every obstetrician and every midwife can appreciate these 6 red flags. If you'd like to know more about acute medical problems, I would like to bring your attention to this wonderful guideline published by the Royal College of Physicians in November 2019, talking about acute medical problems in pregnancy. And the 6 red flags, either in the pregnancy or in postpartum, are emergence of new symptoms, recent change in mental state, that she is not a normal self, any patient who's got new thoughts or new symptoms, any patient with thoughts of self-harm, any mother who expresses her incompetency as a mother, or any mother who's estranged from her children. These are the 6 red flags. And I believe this patient needs to have a care escalated to a specialist level, has an emergency, and should be seen as soon as possible. I think these red flags should be made available in all clinics, and all healthcare professionals should be educated and empowered about these red flags and should be comfortable in asking these questions. How to help, ladies and gentlemen, having screened, having appreciated the red flags, how to help. I think it's important to optimize encounters. So what we do in where we work, the patient who comes for routine antenatal care, she's actually screened. The patient who screened positive actually has got her perinatal mental health assessment within the obstetric unit. So the patient actually does not have to go to a psychiatric clinic or to a psychiatrist who is elsewhere. She actually comes to the pregnancy unit, she actually comes to the obstetric unit, has got a comprehensive care in the same center as well, the same as any other pregnant ladies. For those with mild and moderate anxiety or low mood, support is sufficient. It's important to identify the 6 red flags that I mentioned earlier, and those at risk needs to be referred. If you've got red flags, I think one should facilitate admission and get an expert to review as soon as possible. We should dispel stigmas related to mental health. Please don't say this is normal. Please don't say that this is okay, that every pregnant mother will fail. Please do not address a symptom when it's brought forward by a mother. Please do not downplay her concerns and perception. We should break the stigma. When a woman complains and says she's depressed, that should be addressed. And all of these mothers should be monitored using the Edinburgh Postnatal Depression Score or the GAD-7 questionnaire to look at effect of treatment and to monitor her symptoms. What is the metrics of perinatal mental health? Those with mild conditions, you may refer them for self-help or a group therapy. This can be done by specialized nurses in the community. Those at risk for perinatal mental health diseases, I think IAPT and CBT have been proven to be successful. You only need to focus on those with moderate diseases or those with severe or high risk factors. And those with moderate diseases, a combination of IAPT, CBT, and medications, which I'm going to talk about after this, seems to be the way forward. For patients with severe diseases or high risk group of patients, I think they need specialist care. And perhaps they need a combination of all approaches of IAPT, CBT, and medications. I'm going to specifically talk about few common conditions. I'm going to start off with depression. Now, what are the risk factors for depression, ladies and gentlemen? It can be anxiety, it can be stress, it can be a past history of depression, lack of support, domestic violence, lower income, lower education, poor relationship, single status. It can also be an adverse pregnancy outcome. It can be a traumatic birth experience, or it could be a mother suffering from breastfeeding problems. These are one of the many risk factors for depression. Now, do not assume that it is normal and that every single depression is postpartum blues. That is not correct, ladies and gentlemen. How to differentiate postpartum blues with depression? Blues are often self-limiting. Blues usually only happens within day 2 to day 5. It never persists beyond 2 weeks. There's no functional or psychomotor involvement. On the other hand, the symptoms persist beyond 2 weeks. If the symptoms are associated with functional impairment, that is depression, ladies and gentlemen. So blues tends to be mild. Incidence is 70%. One of the highest known medical diseases to affect a pregnant mother. I can't think of any other condition. It resolves within 2 weeks. Mother may weep, she may be sad, her mood may be labile, she may be irritable, she may be anxious, but there are no functional impairment. And that may be mild to moderate, that is blues. On the other hand, if it persists beyond 2 weeks, if she's depressed, there's diminished interest or pleasure, if there's weight loss, gain, or appetite changes, if there's insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, feeling restless, or excessive or inappropriate guilt, diminished ability to think or concentrate, thoughts of suicide or ideation, that is depression. These mothers ideally need treatment for 6 to 24 months. And ladies and gentlemen, as obstetricians, we should clearly be able to confidently differentiate between blues, depression. The key is the duration. The key is the functional impairment. Condition number 2, bipolar and schizophrenia. Now, bipolar and schizophrenia has got a high incidence of relapse. Those with bipolar may have almost 1 in 2 risk of relapse. Those with schizophrenia, on the other hand, may have a 10% risk of relapse. Now, patients with mood disorders may be on lithium. They may be associated with cardiac abnormalities. You can monitor the dose. You don't often have to completely stop the medications. The take-home message is never stop an important medication for any mother, either in the pre-pregnancy or during pregnancy, without consulting an expert. In this situation, should be a maternal medicine expert or should be an expert psychiatrist who will be able to provide evidence-based advice. This medication should ideally be stopped 24 hours to 48 hours before labor. Now, patients on clozapine, they have got a higher risk of hyperglycemia and GDM. So, of course, they need to be screened for GDM and they need an FBC to take a look at egg granulocytosis. And sometimes patients may need to have self-home blood glucose monitoring. They may have psychological issues. They need additional pregnancy and postnatal support. But contrary to other patients with bipolar and schizophrenia, you need to do one additional step, which is to assess parenting capacity. And this should ideally be done by an expert psychiatrist as to ensure that the care for the baby remains uncompromised. And sometimes you need a multidisciplinary, intensified, coordinated care, ideally done by the perinatal mental health clinic unit. How about patients with mental health issues, with chronic medical conditions? I think we are sometimes masters in managing patients with complex medical problems. But similarly, we should also pay due focus and attention to mothers' mental health, especially among those with high-risk pregnancies. So complex psychological needs includes patients with personality disorders, patients with substance misuse, and patients with domestic violence. 3 other important cohorts of patients, apart from mood disorders, apart from depression. The patients with complex psychological needs are often even more difficult to manage. They may have sudden or rapid change in emotions and in impulsivity. They may have chronic feelings of emptiness, fear of abandonment, threats. They may have self-harm, a question that one should often always ask in every single contact. And they may have intense, unstable interpersonal relationships. Apart from screening, apart from monitoring, they need interagency referrals. They also need to be addressed about safeguarding issues. They need to be assessed by the safeguarding team. And just like clobazam and clonazepam, quetiapine increases the risk of gestational diabetes, so they need to be screened for GDM. Now, what are the other aspects of patients apart from the 3 cohorts that I described? Fear of labor is now a pathological condition called tocophobia. Patients may have significant medical condition or complications screened for perinatal mental health. That includes patients with fetal anomalies, patients who have got prolonged hospital stay or separated from family, patients with adverse pregnancy outcomes, birth trauma, traumatic birth, patients who are vulnerable, and also during COVID, patients who are locked down in isolation in their house. Hope it never happens again. But these are certain patients who have got higher risk of mental health illnesses. So the care should be integrated, just as how they have a stepwise care. Patients who have got mild diseases should be able to be aware. We should need advocates in community levels. The family members should be empowered, and they should have self-help, and they usually benefit from self-help alone. Patients who had mild diseases, I think early intervention in primary care seems to be successful, and all they need is CBT and IAPT. Rarely do they need medications. On the other hand, patients with moderate diseases, these are the patients that need to have their care elevated. They can be managed by a trained primary maternal and a primary child health clinics. They need a combination of three things: CBT, IAPT, and medications. The patients with complex conditions, patients with severe diseases, or patients with high risk, they need specialized mental health care. And you need a combination of medications which are not contraindicated, which have been proven to be safe, and psychotherapy. And that is the step care approach for integrated care of any patient with mental health illnesses. It's important to also document who to call, who's in charge, how to assess care, and a comprehensive birth plan as early as 32 to 34 weeks, especially with regards to the safety of medications during pregnancy and during childbirth and during breastfeeding. What is the role of the obstetrician like me, ladies and gentlemen? I think we should communicate. We should be the link between community midwives, specialized midwives, and the psychiatrists. I think we should be able to network with perinatal mental health professionals. I think obstetricians should be able to identify high-risk patients. I think in the primary care, we should universally screen among high-risk patients, but universally screen all patients for depression and anxiety. We should be able to identify the 6 red flags. If yes, the care should be escalated. We need to talk about safeguarding team for patients with complex psychiatric issues. We need to establish parental capacity, especially for patients with bipolar or schizophrenia. We need to be comfortable to appreciate and to know that medications are safe. Most medications are safe, except for a limited few, such as sodium valproate. Some medications are not contraindicated and safe with breastfeeding, but you need to monitor for GDM, but we need to be well-versed with medications. We need to monitor the fetus with growth scans, monitor for diabetes, monitor for weight gains, which may be indirect consequences of the medications, but we also should be able to monitor her symptoms by using a dedicated questionnaire. The care should be documented, should be in a handheld notes by 32 to 34 weeks. Every pregnant mother should have a delivery plan, especially those suffering from mental health illness. Medications that should be taken antenatally are safe. Breastfeeding should not be withheld. It's important to inform the pediatricians, the neonatologist should be on board. The baby may have some withdrawal symptoms. She also sometimes needs additional support to care for a baby. Few patients need parental capacity. Few patients need safeguarding, especially those with complex psychiatric illness, patients with bipolar and schizophrenia. And you should also ideally see them within the first 3 weeks, because that is when the risk of relapse, the risk of escalation, the risk of depression seems to be the highest. Now, what is the difference between an obstetric-led perinatal mental health services? I believe in patients who came and saw us, we were happy to empower. We were happy to have an evidence-based approach. We were happy to medicate patients, understanding that these medications are safe and that we actually prevented the stigma associated with mental health services. Although not all patients need medications, patients who need medications, like those with moderate or severe diseases, are medicated, because we now know, and we have also empowered our pharmacists, that these medications are safe, these medications are not contraindicated and should not be withheld, especially if a pregnant mother needs one. Now, what have I learned running this joint perinatal mental health clinic, which I established within the MFM framework since 2018? I realized that if a patient comes to a dedicated mental health clinic, which is still within the obstetric clinic, the compliance is better, patient satisfaction is better, the outcomes are better as compared to asking a patient to go to a psychiatric clinic where the incidence of compliance may be lower. I believe more importantly, these patients are not stigmatized. They're treated with respect. They're treated similar like non-other patients. They get good evidence-based care. I believe the obstetric clinic and the maternal fetal medicine clinic is also the same clinic where patients with adverse pregnancy outcomes are usually seen. And so it's easier to screen. And knowing, appreciating the importance of mental health, these patients are often screened. More importantly, it has been a good learning process. I think doctors and nurses and junior doctors who come to the unit now are better aware about the importance of perinatal mental health clinic. They are more comfortable in screening, they are more comfortable in treating, they are more comfortable in managing such patients because they are well aware of available guidelines about the red flags and importance. I believe patients get a comprehensive one-stop integrated care called combined care. They see an obstetrician who's an expert, they see a maternal fetal medicine specialist, they see a midwife, they also see a psychiatrist and a counselor. There's been a two-way learning process, but most importantly, I believe having such dedicated clinics, we have improved outcomes, we've optimized care, the patient gets quality evidence-based care. So what are the non-pharmacological strategies that you can use to manage these patients? Supportive therapy, yes. CBT, yes. Interpersonal psychotherapy, psychodynamic therapy, exercise, massage, stress relaxation therapies, relationship counseling or couples therapies, and nutritional and dietary supplements, vitamin D, omega-3 fatty acids has been postulated to a certain degree. And these are some of the many non-pharmacological strategies. What are the pharmacological strategies? I think being a doctor, it is not about the risk of medication, but it's often always the balance between the benefit against the risk. It is not just about calling the pharmacy to check about safety or Googling up FDA classification, but as doctors, we often have to ask, what is the benefit? What is the science? Having no data does not mean it is not safe. What is the risk if she does not take the medication? What is the gestation that she's on? Is it really going to cause any fetal harm? Having a balanced discussion, explain to the patient, and then advise what is best for them. Being an obstetrician, no medication should not be withdrawn, or no medication should be withdrawn abruptly without having a consult with an expert. Aim is for monotherapy at therapeutic doses as compared to polytherapy. But some medications you can monitor, for example, lithium. For patients with a history of severe mental illnesses, don't wait and watch. You may often sometimes start prophylaxis, especially later in the pregnancy, because the risk of teratogenicity is significantly reduced. In fact, it does not cause. And sometimes intrapartum and postpartum is when the patients are most vulnerable. You may start prophylaxis later in the pregnancy. Medications who the patient has taken antenatally is safe to be taken breastfeeding. There are very, 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 very few medications that are actually contraindicated during breastfeeding. If you're not sure, check. Don't tell the pregnant mother to stop breastfeeding without checking. You need to update the neonatal team. Neonatal discontinuations are not uncommon, but it's important to monitor the baby for withdrawal symptoms. And sometimes these infants need to be monitored closely for the first 5 days. Now, what are the medications that are safe? Almost all medications are safe. SSRIs have been proven sometimes in retrospective studies to cause miscarriage, usual and preterm. One medication among SSRIs which are not preferred is paroxetine, but various other SSRIs are safe. Breastfeeding excretion is low. These mothers can breastfeed. SNRI sometimes increases blood pressure, can cause neonatal adaptation syndromes, but are not contraindicated. Medications like mirtazapine and haloperidol are safe for the mother, for the baby, and during breastfeeding. Antipsychotics are safe. They may cause weight gain and GDM. These patients need to be monitored, But quetiapine is very safe for the fetus. The mother needs to be monitored for sugar, but the placental transfers are low. Breastfeeding is safe. Patients on mood stabilizers, you need to provide folic acid because most of the time they're anti-folate inhibitors. Sodium valproate, usually contraindicated. Lithium, you can check levels. Carbamazepine, you need folic acid. Breastfeeding is safe. And benzodiazepines is not contraindicated, but you need to discuss with your pediatricians because they've got rapid placental transfer. But the principle is, ladies and gentlemen, what is the benefit? What is the risk? What is the balance? Do not stop an essential medication without consulting an expert. To summarize my talk, ladies and gentlemen, perinatal mental health is an important part of obstetrics, and I believe every single person, be it a doctor, a specialist, or a midwife, should be comfortable in managing perinatal mental health. We need more training. We need better awareness to treat the silent epidemic. We need to identify patients at risk, and that can be done by universally screening for depression and anxiety. The patient may have an illness, they have an adverse outcomes. We need to risk stratify patients. I think every obstetric unit should have a dedicated, established perinatal health team comprising of a midwife, a maternal fetal medicine specialist, a psychiatrist to provide holistic care, remove barriers, do not gatekeep. Why these patients should have easy access. Remember the 6 red flags: new symptoms, suicidal thoughts, incompetency, and estrangement for the fetus are red flags. CBT, IAPT are common words we should know. Most medications are safe. Let us think towards perinatal positivity to provide a holistic physical and psychological care because both are equally important for every single one. These are part of the team that I've established in where we work. Half of them on the left are the obstetric team. On the right are the psychiatric team who come once a month, the last Wednesday of the month, to run a dedicated perinatal mental health clinic, which I believe we have benefited as obstetricians, but patients have benefited the most. With that, ladies and gentlemen, thank you so much for your attention. If you'd like to know more information, kindly visit the website at obstetricmedicine.my. Thank you so much for your kind attention.